Good morning, guys. It is the Practice Perfect podcast. We are here another week. It's crazy, right? We had a little break, got to get some things
Yes.
done, right? But we're here. Welcome to the show, Maya. How are you doing?
Oh, I am doing just great. I can't complain because if I did, it really wouldn't mean much because we're too blessed to be stressed about anything.
Too blessed to be stressed. I like it. Absolutely. It's been great. So today, guys, we are going to do a fast, in your face episode on one of the new codes that has come out in the last year that we're still, I think, trying to figure out. And so we thought we would talk about it. Maya and I both equally talk about this. We get this requested a lot from a lot of
Yeah.
APC chapters and education sessions with physicians. G2211, guys. This is the next bad boy on the scene that is causing so much trouble. I went to a orthopedic education in Green Bay, Wisconsin. I had like 40 coders in the room, and they had questions about G2211, about the new post-op code. And so we're talking about this, and I think there's still a lot of misconceptions, misinformation, a lot of inconsistencies on the specialty side on
Yeah.
what it really applies. So we wanted to talk today about the drama surrounding G2211. What about my specialty? So we're going to talk about that. Now, Maya, I think it's one of the longest definitions of a CPT code or a HCPCS code. It's up there. So Maya, in a nutshell, what is G2211?
It's talking about the inherent complexity of a visit. And there's always inherent complexity, but the key term that we really want to keep in mind is that it's longitudinal. And longitudinal is synonymous with ongoing. Ongoing. So if it's not ongoing, then you might have a problem because seeing a patient once a year is not considered longitudinal. It is an implied longitudinal as in ongoing more than once a year as in follow-up visit. So yeah, that's how it is. Yeah.
Exactly. And so, depending on where you live, your region, it's like 16 plus dollars ish is the Medicare
Yeah.
payment.
Mhm.
It does
Mhm.
have, some cost sharing obviously involved. So you want to make sure your front office staff and those who talk to patients understand that. But when we think about longitudinal, the go-to physician, we don't want specialists to feel like they're left out. Medicare never left them out from the beginning. They've always been in this. Now we thought of primary care because they kind of run the show with long-term, relationship patients, but there's a lot of specialists out there who do long-term care for patients, and some specialists you may not think of. Obviously, we think of rheumatology because of some of the complex conditions that you're going to go to just a rheumatologist for. There's a lot of biologics that exist in that specialty, and those who work in biologics. Shout out to Medico CX, one of our favorite biologics coordination teams. And that was actually my first specialty. Like my first job in healthcare was in a rheumatology office, and we had a
Mm.
lot of patients. My physician I work with, she was very popular in the area, and she was the only woman. So you can
Oh,
imagine women with fibromyalgia who back then and maybe even still now, it's considered the made up disease, right? I think it was so funny back in the day, like it was this disease that everyone thought was a made up disease. And if you know
right.
somebody who has it, it is anything but made up, guys. It is
Yeah.
painful, it is
Very
debilitating.
painful.
So a lot
Yes.
of the patients, they would try to get in to see her because she was a woman and she understood, and so had a really good bedside manner, so she was very popular. It was like 6 months to get into her, and things, of course, we're used to that nowadays as well. But they have to do a lot of additional workup for patients. It's not just a one and done. It's a long-term relationship that they are having to deal with flare-ups, refilling medications, making sure they arrange for other services that they need while they are in treatment for these conditions. And I'm in orthopedics, and we may not think of orthopedics because of fractures are acute, right? A lot of the
Yeah.
things that we do in orthopedics but hey, we've got osteoporosis. We have
Yes. Pathological
osteoarthritis.
disease. That's right.
Exactly.
Yeah, yeah.
The pathology of the bone diseases, the joints and things that
Radiculitis, yes,
Mhm.
radiculitis. Yeah, yeah.
The joint pain, the back, the long-term back pain that patients that have, and you have ortho spine, there's a lot of things there. What comes to your mind, Maya, on specialties that have this relationship with patients?
Oh, the list is ongoing. I think about infectious disease. I think about cardiology. I think about um, endocrinology, right? Because
Mhm,
all of those are inherent and they're always are inherent to things that are chronic. But does it mean that condition needs to be chronic? No. But what it does mean is that there has to be an implied ongoing relationship where the patients regularly check in and there
mhm.
is an implied ongoing relationship. So part of the issue that we take is that it's a one and done deal. No, it's not one and done. If it's one and done, that is not considered longitudinal according to CMS definition. They did make an update in the last AMA symposium that spoke of this specifically. And
Mhm.
now you could do this with prevent Medicare preventive visits. So
Yeah.
there's just a lot, and this is any Medicare preventive visit. So,
Mhm.
because the G codes in Medicare are always considered professional, anything that's inherent to that with a Medicare preventive visit can be applied. So think about the chronic, think about the ongoing, think about when your patients need follow up. Then that's when it's appropriate because they're following up on a condition where there is a plan to follow up.
Exactly, and I think of specialties like dermatology you don't think of, right? They're not cosmetic guys. They deal with the skin conditions that are long-term for patients. They're also
Yeah,
on biologics. Yes,
psoriasis, yes,
they're
yeah.
on biologics, right? What happens? You gotta have sometimes insurances want that step therapy, and they want you to go through the hoops to ongoing management, trying to get all of that, therapy monitored for the patients. There's, of
Neurology
course
too, we forgot.
Yep.
Neurology.
Neurology. Yep, absolutely. Um, and a lot of us, both Maya and I work in a lot of these specialties, whether it's primary care or these other specialized areas. And yes, some of them, like with what I deal with surgery, they're heavy surgery. But
Yeah,
a lot of it is long-term management of conditions. And we want to make sure that we're seeing that in the documentation. We can't help you as physician if you don't help us. So we want your teams to be there with you and helping you manage the documentation. There's ways to manage your EMR to make it, so you're not working harder, you're working smarter within your templates and your macros to make it clear. This patient, I'm going to pull in this macro that I want to say this is specifically, this patient is part of ongoing management for this condition, this single serious condition. And whether or not they're new to you does not mean you can't use it, right? It says it's for new or established patients
yeah,
with your evaluation and management service. It's not a standalone code. It has to have its parent code. You have to see them face to face, right? And then you can apply this at any visit, could be any day that you see them, as part of this ongoing management.
yeah, yeah. And I think there's a lot of misconceptions about it. And I think one of the things that, from a documentation perspective, we need to make sure that, like you stated, that the condition is ongoing. And that it there is for follow-up, right? Or labs that are follow-up. So when you are planning for the patient to follow up and there's labs or there's something that you're doing to manage that patient for the next visit, then that's when the G2211 is most appropriate. And that's what, as coders, as auditors, that's what we're looking for. I just
Mhm.
audited a slew of charts where everything they did was G2211, but it was
Yeah.
justifiable because they
Yeah.
planned on coming back because they're saying follow up 3 months, follow up 6 months. Regardless, if there's a plan to come back and they are managing a problem, regardless if it's chronic or not, it's eligible to be billed. And it's worth that extra $16 because you're spending that extra time to make those plans for that patient.
Exactly. And if you're wanting to understand things a little bit better, the NGS, if you're a part of NGS, they had a great FAQ on their website for G2211. A lot of questions about, incident two and telehealth and all these things that we always get questions about. And, telehealth is telehealth, right? It's the spoon feeding they keep doing. But as of right now, we're using the E&M codes, right? So anytime you're using E&M codes, if you're using them and it applies to your patient, there's no reason you can't use it because it's with those codes. Mid-levels, or I should say non-physician practitioners, sorry guys, they also bill those codes because they are billing those. They're following a plan of care potentially, right? So whether or
Yes.
not you're doing incident 2, appropriately or not, obviously there's a lot of, horror stories out there, people doing it wrong. But if you're doing it right and you have a plan of care you're following the payer rules, and you're billing an E&M, and this applies, this patient has this ongoing management, then there isn't a reason you can't, according to NGS. But always check with your local MAC to see if they have a different, take on it, because they're the ones paying the bills, right? So
Right.
make sure that you're following your payer rules, right? Now, and there's just a lot of misconceptions in general. I think when you're out there, I'm going to talk about social media, for instance. There's a lot of people that have their opinions that are just that. They are opinions.
Yes.
And not to say that Maya and I don't give our opinion, what we think about
We got
codes,
a lot
right?
of opinions.
We do. We do have a lot of opinions, but if we're going to tell you something, it's always going to be backed by regulatory guidance.
Yeah.
This code has guidance, but it's not replacing clinical judgment. So physicians have to be in charge of this. And I hate to say, sometimes physicians just want their coders to code for them on everything, right? But we really need physicians involved here. This is clinically based code selection. So we want them to make the statement. Coders should not go beyond and start practicing medicine all of a sudden. Right? They didn't go to medical school. We didn't go to medical school. We can't start practicing medicine just out of the blue. We have to go by what is documented.
Right.
So get that in place. And what about auditing, Maya? What should we do about auditing this code if we're not already?
Well, I mean, like in my experience, shout out to FVMA, that I've just completed their audits and things. And I think one of the biggest things that I look for is the ongoing management, right? The ongoing management with the plan, with an assessment and a plan, not just an assessment, but a plan for the patient to get labs, the plan for the patient to return, the plan for patients to discuss other conditions when the patient comes back. So I think a lot of times it gets very, very misconstrued. And one of the things that I found is that when the documentation is minimal and there's minimal information regarding the assessment and plan, it's not justified, right? It's the same with G0545. It's the equivalent for the inpatient for infectious disease, but it has the same premise. And so when you're dealing with those types of things and when you're looking at the documentation, you want the assessment and plan, and you want the physician to document a plan for the patient to return.
Exactly. So, you can audit last month's charts and see if you identify any miscomplexity opportunities, identify those patients, flag them somehow so that you can make a plan for the next time they're in to capture that. And, make sure that you're also checking payers, right? Not all payers have rejected this code. Some have switched to their own Medicare only plans, like United Healthcare last year switched to saying, we're only going to cover this for our Medicare plans because it's a Medicare covered code. So to them, they're like, we're going to take it off of our commercial benefits. So make sure you understand what the payers do. And if you are primary care, I know the primary care organization, the Family Practice Association, had a matrix out there. And I think they update it. But so if you know somebody, they can get you a copy. But other than that, make your own, right? Make your own matrix. Do the work, do the legwork. And all of you software companies out there that are creating tools, AI or whatever, make sure you're thinking about your clients and what their specialty is and what their needs are, and tailor your product to helping your client if that's who you're trying to capture for, because I think that's something we're missing. It's there seems to be this one size fits all approach to software these days, and it's not helpful to anybody. And so
Yeah,
we
yeah.
need to be sure we're thinking of that and get to know the code sets for your clients. And if you don't understand coding, and maybe you shouldn't be putting out a product about coding. Maybe you
Yeah.
should bring a consultant on, like Maya or I, which we do work with software companies, to help you build something that will make sense to the physician practices, right? I mean, come on.
Yes, yeah, yeah, yeah. And it's really interesting that you say that because a lot of times providers, specifically specialists, always think that the Medicare new codes or specialty G codes are just for primary care. And software companies tend to focus on that. But in reality, they're designed for everyone who has a stakeholder in the patient's care. And I think it's really worth software companies to consult like Jen and I, uh, with Jen and I to uh, investigate the usage and its effective usage so that if a provider is missing out on an opportunity to bill, that AI software can capture that and identify, okay, this G2211 is here, or this G04545 is here, or even long prolonged services when there's documented
Mhm.
time. So,
Yeah.
uh, there's a lot. I mean, I was on the infectious disease website and they talk about the G2211, they talk about the G0545, and they can be used in tandem depending upon the place of service. So we're talking about a specialty. We're talking about you as a provider, you as coders, coding for your providers and appending what's appropriate for them to optimize the revenue for their service. So it's really important for providers as well as coders to work in tandem to see what opportunities they could capture and if they're allowed to append with their approval for them to bill for those services.
Wonderful stuff. Well, guys, I hope you enjoyed this fast in your face episode today on G2211. We are very excited. We got to jump on today and give this information out to the world. So thank you for joining us. We'll be back next week with an all new episode on rejections versus denials. There is a difference. And we're going to unpack that. We're so excited. So thank you for joining and thank you for taking the time always to, of course, support the Practice Perfect podcast. Until next time, guys. See you later.